So this is high yield respiratory med surge information that will be important to you. So for me, I struggle with this, and I'm hoping this can help others. For mechanical ventilation, always assess the patient before you check the machine. That's with any kind of machine, but whether they're on the chest tube or IV, whatever the case, check the patient first. Okay, that there's two different alarms that you'll notice with the mechanical ventilations. So the high pressure alarms, they can indicate resistance, which would be like secretions, coughing, biting, or kinked tubing rather. Low pressure alarms can suggest a disconnection or an air leak. If the ventilation fails, disconnected, and then you would use the ambu bag, which is your little respiratory bag, and then you have the mask. You squeeze it, and then you're going to manually ventilate the patient that way with oxygen. Okay, then suctioning, that's only used when there is coarse breathing sounds, visible secretions, reduced oxygen saturation, or high pressure alarm. So we have to pre-oxygenate the patient first and use sterile technique always, because remember, there is the trach is exposed, correct? Okay. And then insert the catheter without suction. So and then you want to apply suction when you're withdrawing. Limit like each pass like 10 to 15 seconds. And you want to stop if you see hypoxemia, bradycardia, or abnormal heart rhythm. Then finally, for a chest tube, keep the drainage system upright and below the chest level. Do not routinely clamp, strip, or milk the tube. Titling in the water seal chamber is generally expected. Continuous bubbling in the water seal indicates an air leak. So if the tube does come out, a patient cover the site immediately with sterile occlusive dressing and notify the provider. So remember this. High pressure means resistance. Low pressure means a leak. Suctioning, you have to suction when you're withdrawing the tube, and keep the chest tube system below the patient's chest. Thank you very much and have a good day.